Welcome back to Series 2 of Pager, which is well and truly up and running now. Today we talk to Dr. Adam Cifu, who co-authored the book Ending Medical Reversal with our previous guest, Vinay Prasad, in 2015. Adam is a general internist, or a GP in UK terms, and also a professor of medicine at the University of Chicago. He divides his time between seeing patients, teaching, and research into evidence-based medicine. In this episode, we talk a lot about decision-making. What is enough evidence to adopt practice? Why are some practices later found out to be ineffective or even harmful? How easily does a practice change when new evidence comes along? And how should we make decisions when the evidence isn't quite what we'd like it to be? A quick plug, if you enjoy this episode, then you might also like our previous one with Vinay Prasad on fixing the clinical trial landscape, one of our first episodes with Dr. Margaret McCartney on evidence-based medicine, and also our interviews with Richard Horton, Magdalena Skipper and Eric Rubin, editors-in-chief of The Lancet, Nature and the New England Journal of Medicine, in which we talk about the world of scientific journals, the role that they play and the challenges they face. So without further ado, I give you Dr. Adam Cifu. So Adam, welcome on the podcast. It's great to have you with me today from Chicago. We're going to talk a bit about medical reversal, and I was wondering if you could just define that for me and just give us a bit of an introduction towards that.
Sure. We define medical reversal as a phenomenon where a treatment or procedure or medical intervention that's already been accepted and sort of deployed into the population is tested and found to be ineffective. It may be no more effective than no treatment at all. It may be less effective than the former treatment that replaced. And then we need to go about the work to say, we've been doing the wrong thing for, 5, 10, 20, 1,000 years, and we need to pull back and stop doing the treatment that we've all gotten used to doing.
And do we have a sense of how common this is in modern medicine now? Then?
Yeah, I wish we did. If you think about it, it's sort of impossible to know exactly how common it is, because what you would need to do is you need to sort of look at everything that physicians do. You'd need to come up with all the things that we do which haven't been adequately tested, go back and test all of those things, and that would be not only an entire career, but the entire research funding, of the United States and the UK to pay for it, probably. But we have done a number of studies, both Dr. Vinay Prasad and myself and him and his team, to try to get a sense of it. What we do know is that when you look at the literature and when you look at various journals and look at what they publish, it looks like that somewhere between 10 and 50% of the articles that are published that look at an accepted treatment being tested overturn that accepted treatment. Okay, now that probably speaks more to editorial decisions and the interest of researchers on studying things, but it gives you a sense that there's a good deal of medical reversal out there. It also certainly varies from field to field. There are some specialties which seem to be, especially prone to reversal. And that's mostly specialties where they've accepted doing a lot of things based on kind of the biologic plausibility of it, but they have not gone through the testing in a robust way of what they're doing yet.
I guess it's probably important to add that these are things that people have singled out to test in the first place. Whereas
Absolutely.
That must be a fraction of the total medical practice. Actually, there's probably quite a lot that we're not even looking at testing that, even though it has biological plausibility, might not necessarily be effective.
Oh, you're absolutely right. And there was a study, I'm not even sure you could call it a study, almost a review that was published back in BMJ, probably, I think it was maybe 2013, that looked at something like 5,000 practices, okay, that we kind of all do and we accept. And it sought to look at the evidence base behind those practices. And it was really striking because out of that number, something like 7 to 12% of them were clearly things that we just shouldn't be doing, okay? That there was already data out there that said, this is wrong, don't do it. About 25%, if I remember correctly, were things that were really well supported by the literature, and that's like, okay, we're doing the right thing here. And then something like 50%, we just had no idea. It was stuff that we were doing actively, but there was not a robust evidence base behind it. And so those are the things that if you were going to say, wow, we got to get rid of medical reversal, the first thing you'd have to do is test those 50% of things that we're already doing, which we don't know if they're effective.
Because certainly there seem to be different categories. There are treatments that haven't even been tested at all and have been carried through, because medicine seems like this evolutionary process from things that we were doing 100 years ago and random things that get carried through and nobody's tested. And then on the other hand, we've got ones that have been subjected to trials, but they've had methodological issues with them, or actually have just been subject to random chance, and you've got a p-value of 0.45 and it's been accepted there. Which ones do you think we're most concerned about then, Hill?
So when I think about like how do you address a reversal, right? I kind of prioritize two things. One is new practices, because I feel like knowing what we know at this point, and having a fairly robust practice as far as being able to practice evidence-based medicine, it seems like in 2020 we should not be adopting practices which haven't been robustly tested. So I feel like the one thing we need to do is say, okay, before we adopt a new practice, let's make sure that it works and it's safe, and maybe you'd add to that cost effective. On the other hand, maybe look back at things that we do and look at things that are particularly expensive, particularly common, and have the potential to harm people, and look at those, okay? Because there are certainly things out there that we've done for a long time which haven't been tested, but I don't know, cost $4 for a 2-week prescription, and which we don't do that much. And there's not a whole lot of incentive to look at that. But if we're looking at an arthroscopic knee surgery, which is costing our health systems hundreds of $millions a year, which is not robustly tested, geez, that sounds like something we should go after.
Because certainly incentivization for testing practices which have already been approved is a really tricky issue. And it seems like most of the pressure is in the opposite direction. What incentives are there to stop a costly treatment, particularly when, as in the UK and in the US, people aren't always paying out of pocket for their treatment. So the companies and perhaps even the doctors who are using it might not necessarily be incentivized to, and the people who are thinking about it might not necessarily have the resources to actually go ahead and test this. How do you think we can address that issue of actually incentivizing people to overturn practices which are already approved, but isn't necessarily that glamorous a role, I think it's fair to say?
Oh boy, no, you're totally right. And I would add to what you say is that there is not only not great incentives to test it, because as you say, people aren't paying out of pocket for the most part for the treatments they're getting. But there's actually really negative incentive because physicians, physicians in private practice may be actually making money off of it. The companies that are manufacturing the medications, the devices, the surgical equipment are making money off of it. And then there's also almost some cognitive dissonance, right? That the physicians who are doing it, they're generally not doing it just because it's graft and they're trying to make money. They really do think it works. And so it's hard to say, boy, I'm going to test this thing, which I've been doing, which seems to be helping my patients and which I'm making money off of. There's no incentive for that. How do you incentivize it is hard, because the things that we've seen tested are sort of tested by really like courageous physicians looking at gospel in their field and going after it. Whether it's orthopedists looking at the procedures they do, whether it's cardiologists looking at who in fact should we be doing percutaneous coronary intervention on, oncologists who are saying, boy, are these novel chemotherapies or biologics actually living up to the promise of their mechanism? Those are sort of impressive people, and whenever I read one of those articles, I'm like, that person is brave. So how do you incentivize it? I mean, I think part of it is to say, we in the United States always talk about, when we reform our healthcare system, we have to figure out a way of intelligently having the patients have some skin in the game, right? Where you would not be accepting a novel, expensive therapy if you were paying for it unless you knew that it was going to help you, okay? So that's probably one place in healthcare reform that we can help. And then on the side of adopting therapies, for us, it's saying, like, we need to make sure that treatments are not approved unless they have robust data. And if there's a reason to approve them prior to having robust data, we need to make sure that robust data is in the pipeline, and that if it's not achieved in the next 2 years, say, that drug, that device, that surgery is coming off the market until we have that.
Which is the case with accelerated approval of drugs by the FDA in theory, but when it comes to practice, we see a rather different set of circumstances, and we end up with drugs that don't have the evidence behind them just languishing on the market until they become commonplace.
Yeah, I'm not sure I would say languishing on the market. I might say thriving on the market. Until we have the data. Yeah, I mean, I think you can count on one hand the number of times that the FDA has had the courage and the strength to say, you told us you would have data. We don't have the data. You need to stop marketing this drug. Unfortunately, even in those cases, often the drug is approved for another indication, and so its use in this unproven indication may even persist.
And a question, I guess, that some might use to push back on this is, what rate of reversal is actually a price to pay for more rapidly bringing positive interventions to the market? That actually, we might let a few slip through that in the end are proven not to work. But if we bring a lot of effective interventions, maybe a year sooner towards patients, is that a benefit overall? How would
I hate that.
Yeah, how would you approach that?
Whenever someone hits me with that, and I know you're posing it in another person's voice, but it makes me crazy. Because one, in today's world, we see so few enormous advances, right? We're seldom talking life and death. We're often talking about, maybe this is a little bit improved quality of life. Maybe this new therapy is a little less invasive than what went before it. Maybe, though, uncommonly, it's a little less expensive. We're talking very small changes, okay? And so I think that if there is a delay in adopting those therapies, it's overwhelmed by the number of therapies that we've adopted that have been shown to be ineffective, harmful, so expensive that they're breaking our healthcare systems. Dr. Prasad has done a little bit of work on trying to quantify the delay. He, as an oncologist, has looked mostly in the field of oncology and has mostly compared the delay that's caused by, instead of going on surrogate outcomes, that would happen if you waited until the clinical outcomes. So instead of looking at cancer progression, you actually looked at mortality. And the numbers he's come up with is about an 11-month difference in the entire scheme of drug development, which is often a decade. So you're talking, in percentage terms, a very small difference. Now look, is it true that somebody will not get the treatment which might be effective? Might somebody die earlier because something is being hung up in the approval process. It's possible. But we know for a fact that, some people have been harmed, and much money has been spent on practices that exist on the market for 5-10 years before we know that they're actually ineffective or harmful.
And I think the 5-10 years point is a really good one there, that actually the longer that the ineffective ones remain on the market, the more they skew us towards wanting a higher evidence standard for
Yes.
the ones that are introduced, almost to the extent that if we reduce that time period so much, we think actually, why wouldn't we just to maybe say 3 months before reversal? We're almost talking about instigating a clinical trial in itself on the population just after something has been introduced.
Right. And if something gets accepted without reasonable data, it's hard to pull it back. On the one hand, as you say, the incentives to pull it back are often not there. It's difficult because you're often trying to, prove absence of effect, right? Which is sort of a philosophical, quandary. Can you actually do that? And then I would say and we know this very well from some really nice research, a decade or more ago, that once something has been shown definitively not to work, it then will take a decade for people to stop doing it. So once you've actually proven that something's ineffective and proven basically that a reversal has occurred, it's not like everybody drops doing it the next day.
Which is very different from taking up a new practice, which I think comes a lot quicker.
Yeah. Not sure why that is. I guess as physicians, we like to do things to help people, and it's sometimes hard to admit that, we don't have much to offer. I have to say I see that in my own practice of people with early cognitive impairment, early stages of dementia, where I still really feel that for most people, aside from risk factor reduction, I don't have much to offer. Certainly, there are drugs on the market that there's very weak data supporting their effectiveness. And it's sometimes a challenge for me not to prescribe those when the patient, or often the patient's family, is saying, can we do something? So I guess I do understand what the issue is.
And I think pain management is probably another good example in this area, that actually for lots of patients there are tragically few options for them, which has led to perhaps some doctors and some patients turning to drugs such as high potency opioids, which can have negative effects in the long run, just so that something is being done, at least, because it's very hard to say no.
Right. The pitch that, I'm sorry, I can't help you. Pain is part of the human condition, is not a great way to retain your patients. And you almost wish in that category, and I don't know, maybe my evidence-based medicine friends will throw me out the window for this, but probably not, that it was easy. It would be easier to do sort of N of 1 trials, in your own practice when you're treating pain, to say, look, I have these drugs that might help you. Let's play around with them for the next couple of months, see what actually helps, and then you, as my patient, and I can have a discussion of like, okay, listen, we figured out what works. Let me explain to you the harms of this medication that I know of over time, and you let me know if the benefit that we've witnessed is worth accepting those harms. Because if a patient goes into it saying, listen, this long-acting opiate absolutely changes my life, and I'm willing to accept the risk of addiction down the line, I think that's reasonable to prescribe.
And it also make sure that there is some finite endpoint, and you really are assessing something along the line, and this isn't just something that somebody is put on and then left on for years without those side effects being managed or even talked
Agreed.
about. So having something, it's perhaps different to have a drug that's ineffective but a patient finds effective overall than a drug that is ineffective and a patient finds ineffective as well.
Right. I think that's a great point. And the way you say that also sets you up, almost like a contract to say, we also have some sense of how we're going to play with this going forward. That we're going to say, look, we're going to retest this in 3 months. We're going to let you make the decision if treating you with this is still worth it.
I almost wonder, kind of more broadly, what would happen if we removed ineffective interventions with the same level of evidence that we introduced new ones, and what situation we'd find ourselves in, because it seems like the bar for removal is much higher than the bar for introduction in some cases, probably for reasons that we've alluded to.
Yeah, right. Imagine if, somebody tried to stop a therapy because it was found to be non-inferior to something that we'd used in the past.
I think
there'd
be
probably
more pushback.
be absolutely right. The companies that made that would be looking at all the subgroup analysis and saying, well, yeah, it's equally effective, but there's this, and this, which would say we should use it. While things are being approved based on non-inferiority studies all the time, sometimes inappropriately.
To what extent you've done a lot of work into evidence-based medicine, and to what extent do you think we are better at applying it to certain fields and certain types of interventions than others?
I mean, I think that is true. Well, so certainly, there are fields, right? Cardiology, oncology come to mind, where there is just an ocean of randomized controlled trials out there, right? And it's like in the genetics of those fields that treatments are going to be approved or considered based on enormous randomized controlled trials, okay? Those fields are certainly not without their problems, right? Those are fields that have enormous pharma money involved in designing studies, of interpreting the studies even, of just determining which studies are going to be published and which are not. And so although the trials are being done there, maybe we're not perfect in our EBM approach. On the other hand, there are other fields, pediatrics, obstetrics, orthopedics, where you look at the literature and I think certainly even people in the field would say, boy, our evidence base is wanting. And so there's EBM problems in those fields as well, but in a different way. So maybe we're challenged everywhere, but just in different ways.
And what do you think perhaps underlies that difference that you just talked about?
That's a good question. I mean, I think it's probably different in every field, right? Obstetrics, pediatrics, there's always a hesitancy to conduct trials in children, in pregnant women. In orthopedics, I think it is so convincing, the biologic plausibility for things, right? If an orthopedist shows you an MRI of your shoulder and says, look, the cartilage is all messed up in here and I can go in and fix it, right? You're going to sign up for that. That sounds amazing. And so there's less incentive to say, let's actually compare a bunch of people who've had that surgery and people who've just, done some physical therapy and see which is better.
Though again, in this scenario, it's not a large step to look at this surrogate endpoint and say, even we can take 1,000 members of the public and we can do an MRI on their knees, or we can take 1,000 people who have had a scan done incidentally, and we can show actually what I think is increasingly recognized, that the degree of damage and the degree of incidental findings that you can find in a patient doesn't necessarily correspond to the degree of pain or disability that they're faced with. Why is that argument not that so compelling in these situations?
Yeah, you undermined me as you're making that point. I was going to say, so why is that argument not compelling? But you turned around and asked me. I'm not sure. I think so in, my practice. Where it probably applies most is back pain, right? Um, and I am very good about explaining to people the course of back pain, to making sure there are no red flags. Having been absolutely taken down by an episode of back pain once in my life, I can have quite a bit of empathy to it as well. Um, but when you're in front of a person and you've gotten to the point where you're imaging their back and you see abnormalities there, and you're trying to tell the person that, these are the abnormalities, but these don't really tell us anything. There's still, even hearing that and even knowing that as the physician, you're with a patient. You're with a patient with abnormal anatomy. I think that pushes you along. And clearly the answer there is it should be harder to do imaging on people that we don't think are going to benefit from it than it is. I'm not sure if that's, I think it's easier to do the imaging in the United States than it is in the UK, but I think all of us have too easy access to these things that are just likely to send us down the wrong path.
And certainly imaging is something that can be subject to proper investigations to determine whether that leads to decent consequences down the line, even if imaging is only being used to point you towards a certain intervention. A well-designed trial can show you that.
As I try to think of examples of this, and this doesn't really get there, but it's an interesting change that I've seen over my career, and an interesting way of approaching it. When I trained, which was not generations ago, right? I'm not that old. When someone came in and it seemed like they had nephrolithiasis, we're passing a kidney stone, our diagnostic test was a urinalysis. It was like, boy, this person's in pain, seems like they have a kidney stone. Do they have blood in their urine? Done, And then we got CT scanners everywhere, and CT scans are great in that setting. And so everybody was getting CT. And you don't need a CT scan. It almost never changes management. And in an effort to pull back, what a group of actually emergency room physicians said is, let's randomize people not to a urinalysis versus a CT, but a CT versus an ultrasound, which is sort of useless in this setting. And they didn't look at how, right, much cheaper, certainly without contrast, so less harm involved. And they said, we're not going to look at the sensitivity and specificity about how good these tests are at picking up kidney stones, but we're going to look at outcomes. We're going to look at how did people turn out 6 months and a year later, based on pain medications, duration of pain, kidney function. And it turns out that whether you do an ultrasound or CT doesn't matter. And that was sort of a nice way of convincing people that we should pull back on an imaging procedure.
And if you take a far broader view of it, stepping back and you say, well, where else could we allocate these resources to? Then you think actually the CT scan is worse than neutral in this circumstance.
No question. And I think, unfortunately, healthcare financing is so complicated, no matter what system you're in, that kind of playing that zero-sum game, where you're saying that wasting money on this is actively taking money away from something else, is harder to show than it should be. I think NICE in the UK does a hell of a better job than anything in the United States. But it's still so diffuse, and it's so hard to make that argument, especially to the people who feel like their care is being limited.
And perhaps, I'm wondering if it's also harder in the USA because it's less clear to say that a saving is going to translate into money spent effectively on healthcare somewhere else, whereas actually a saving could, down the line, to be slightly cynical, translate into just more profit for one of the players involved. Because I think that probably happens a bit less in the UK.
Right. I mean, we've certainly been aware of that during COVID, where, we were certainly very busy in the hospital, but we were not, I say were, right now where I am in Chicago, we're at a good place, but certainly nationally we're not. But if I go back a couple of months, when most of our resources were going to treating COVID, and otherwise very few people were coming to the hospital to manage their blood pressure, hell, even to manage their MIs, insurance companies were making a killing because they were still taking in people's money, but not paying for the usual preventative health care that we do. And that was a good example of, the health savings were probably going to the insurance companies' bank accounts rather than to better childhood vaccination programs.
Mm. And I wonder, I was going to say something a bit earlier about whether this want to kind of give patients options, to give patients interventions, could be slightly grounded in a reluctance to actually admit uncertainty about what is going on, particularly with, I used the example of back pain, looking at MRIs and things, that actually it's hard to tell somebody, actually, we don't know what the cause of your back pain really is. I have maybe some mechanistic understanding of how the interneurons are firing or the neurons are firing, but here is this very tangible thing that lets a patient know that you know what you're doing in a way. Do you think that that plays a role at all?
I do. And I think maybe it's less the uncertainty, because I think most physicians are comfortable with uncertainty. It's so much of what we do in practice. Certainly, I think patients are less so. And I see this self in my own life, right? I'm more comfortable with uncertainty when I'm the doctor, and I'm less comfortable with uncertainty about myself when I'm the patient. And I see that on both sides of the bed. I think though it's also, there's this feeling among patients that we should be able to fix everything, and there's this expectation that you go to the doctor and you're gonna be better, and we as physicians, we kind of welcome that because we're healers and we want to do wonderful things, but I think we all need to get better, doctors saying it, and not really patients but humans accepting it, that we're not perfect, and as time goes on, you kind of aggregate disabilities and changes in your life, and you should fight like hell to fix the things that can fix. But the other things, often chronic back pain, you get to a point where okay, we need to admit that this is going to be you, and you should live with this. It sounds kind of dark and grim to say, but it's probably true.
It's a hard thing to say, and it's probably also hard to actually point to the counterfactual to what has happened, to say actually patients might think, oh, well, my back pain is still bad with this, but it could have been worse without it. And therefore it's justified, or actually it could have been better if we hadn't have done this. And it's very easy to see how our own cognitive biases can play out in these situations and conflict with what a proper trial would have shown.
Right. And we as doctors do that all the time, right? The person who comes back to me after their carpal tunnel syndrome surgery and is like, my hands are still numb. And my reaction is, well, yeah, it's not really going to fix things, but we're just making sure that you don't have worse disability as time goes on, right? So we're wholly complicit in it.
And speaking earlier about evidence in the time of COVID-19 and the pandemic we're facing currently, to what extent do you think that this changes the need for speed and facing something very unknown at very short notice? Does this change how we should approach the evidence with which we introduce new practices, and how we, in general, our approach?
Yeah, I think this is an super interesting topic, and a lot of people have written, I think, really nice things about this. My take is that it doesn't change the evidence we need. There are certainly, as physicians, we all know, times that you are in a crisis with an individual patient, and you're like, hell, I'm throwing evidence to the wind and I'm doing whatever I can do to try to make this person better. That's a fact, and that's medicine, and that's fine. COVID is not that, right? COVID is a disease that is affecting, now millions of people, and it's something which is going to be with us, maybe forever, certainly for years. And we need to know that how we're treating people is correct. And what that means is that if you have a new therapy that you think might work, whether it be, remdesivir, hydroxychloroquine, convalescent plasma, you need to say, look, early on, I'm going to take advantage of the hundreds of patients that are coming through my door and begin running trials with it. Does that mean that for the rare thing that really does work, that some people early in the course are going to get a placebo treatment and maybe not do as well? Absolutely. And you just got to accept that. Though I think on balance, what's going to happen is that, for every one treatment you find out which decreases mortality by 5%, which would be, which would be spectacular, right? You're going to keep people, millions of people from receiving treatments which don't work, are potentially harmful, and all cost a lot of money.
And perhaps it's easy to underestimate the harms that these such interventions can actually, they could run up to 5% in a critically ill patient.
No question. And if you're talking about a drug, in a setting like this, think about hydroxychloroquine. A relatively inexpensive, well-tolerated, relatively harmless drug, okay? But if what happens is that we give that to everybody in the world, okay, who presents with symptomatic, coronavirus infection, we are all of a sudden treating millions of people, and millions of people more than are currently treated with hydroxychloroquine for their rheumatoid arthritis or CPPD, whatever. We're quickly going to be seeing side effects and costs with a, well-tolerated drug. Mostly where these trials need to begin is, right, we begin them in the sickest patients, see what we can do for those people, and then maybe begin to extrapolate backwards to less and less sick people.
And I wonder, are there any situations in which we can support interventions by only a mechanistic understanding of them without these proper trials? And I wonder, I'm kind of thinking here about policies and maybe face masks or something like that, where they seem more appealing to a mechanistic understanding of them, perhaps because there's not all of the literature around how such an understanding can be flawed. But I wonder, what's your take on this, whether it is you should be steadfast in your approach to studying things in randomized controlled trials?
I was going to, in the middle of you talking, I was going to scream never, because I would say overall, I think bioplausibility is evil. It so often does not translate into effective therapies. Bioplausibility is absolutely key to figuring out what you're going to test.
Let's go next, perhaps.
Right. But then you got to get through a trial to say, this bioplausible treatment actually works, while these 9 other ones don't, to figure out what you're going to do. Mask wearing. Mask wearing is very bioplausible. There is actually pretty good surrogate endpoint data for it, right? We know that a whole lot fewer respiratory droplets get out there. We do have good observational data from the past, that masks work to prevent spread of infection from infected people to other people. We've got generations and generations of surgeons who've worn masks in the operating room for just that reason. And masks are cheap, harmless, easy to tolerate. So that's an example where certainly bioplausibility and less than trial data is more than enough for me. So there are places where even a complete fundamentalist about evidence will say, sure, that's fine.
Yeah.
Fundamentalism in all forms is bad, and so even in evidence-based medicine, that's true.
An interesting thing that's come about recently is some claims that masks can make you hypoxic, and actually I've found myself very amenable to the bioplausible explanations of why that doesn't happen, and the anecdotal and observational points there.
They're not the most comfortable thing in the world. On a hot day, they're uncomfortable. I honestly think that when I run up a flight of stairs with a mask on versus now, I think I'm probably a little bit more out of breath at the top. But who the hell cares? You compare that to one hospitalization, and that's something I'm willing to take. I guess being polite to other people is always a little bit of a challenge, but it doesn't mean we shouldn't do it.
Because we've talked a bit about how maybe the FDA and regulators should be stricter in the levels of evidence that they suggest. And I know certainly Vinay has been great on saying how actually it wouldn't take very much for companies to very quickly fall into line and produce better evidence for interventions if suddenly approvals weren't coming in. But do you think there's anything else that can be done in this sphere?
Yeah, I mean, I'm much more interested, given what I do, what my role is, about this physician education side of things. And I really think we have to start from the beginning of medical school instead of beginning medical school with teaching people basically the foundation of bioplausibility, teaching them physiology and pathophysiology, which I think is important, and it's important for physicians to know well. But teaching that first makes it seem of the utmost importance, and I think sets people up to adopting therapies without a robust evidence base. I really think we need to move on to medical education, which starts people thinking about why are we doing things, and why are we doing things is not because this is how ATP is used, but it's because this trial was positive. So I'd love to see students, enter medical school, go through their clinical training with the answer to every question is, why are we doing this? Well, it's because studies X, Y, and Z show it's the right thing. And if not, it's because we don't know why we're doing this. It seems to make sense because of this. And then maybe in the kind of, post-clinical years when students have learned their doctoring, they can go back and say, okay, let's fill in some of the holes here, where you learn the important science, which leads to hypotheses, or the science that we can honestly fall back on when the evidence is not there. That may be a dream, but we'll hope for the best.
Speaking of other dreams, this alludes to the idea that actually the human body and the systems that we're trying to make changes to are so fantastically complicated that we are resorted to looking at broader outcomes rather than this mechanistic understanding. Do you think this will change at all in any areas in the near future as we learn more?
Yeah, no, it's a great question. I'm generally an optimist, and I really do think that eventually the answer to that is going to be yes. I do not think it's going to be in my career. I am constantly struck by how complex the human body is, and I think we are all constantly surprised by things that either work and we don't know why, or don't work when we were sure that they would. But I think that's far off. And I think, although it's not ideal, for a while it's going to be, how does this work in a large population? And my fear, and I think anybody who really preaches evidence-based medicine, when they're honest and thinking about it, should share this fear, is that there are certainly drugs that get that are found to be ineffective by randomized controlled trials, which are probably effective in a small group of people. And there are certainly drugs that are accepted, which have no effect or maybe harm in a small group of people. And I hope that the first step towards what you're asking is to say, wow, it would be great to have better, kind of pharmacogenetic understanding. So we could say, I got this person with high blood pressure. I know a lot about what they're going to respond to well and not well as an individual, and that's going to make my decision. Do I give them a thiazide? Do I give them a beta blocker? Do I give them an angiotensin receptor blocker?
And in a way, what we're talking about is our mechanistic understanding is transforming the preclinical and trial pipeline, the hurdle that we should be going over before it gets into clinical practice. I think I'd agree in saying that it should remain clinical endpoints or very well proven surrogate endpoints.
Yeah. But wouldn't it be amazing, if we were to get to that point where you could do all the work in the lab, right? To say, this drug will, with 100% certainty, work in this person with this, genetic signature. I mean, that would be incredible. That's what we should all be dying for. We're not there yet.
Again, we have this question with drugs and interventions being approved, that it's not necessarily the case that all of them are approved on inferior trials or no evidence at all. There's also just a statistical nature to running multiple trials across multiple conditions that mean that lots of them can sneak through. How do you think we can address this?
It's something that, and this goes back to, the earliest users' guides to medical literature and the earliest descriptions of what evidence-based medicine is, right? That the evidence-based medicine is not looking at the last trial and doing what it says, right? It's incorporating your understanding of biology, your clinical experience with the best available evidence, okay? And so, if your clinical experience and your medical knowledge line up with a treatment which is, of just over the borderline statistical significance, you're probably pretty safe. Certainly you may say, I need to study that more, I'd love to have more data. But you're going to be okay there because your kind of pretest probability of success is high, right? If, on the other hand, you're saying, what I do is I read the abstracts of things published in the New England Journal and I adopt that therapy, that's not evidence-based medicine, because you're going to adopt a lot of completely implausible interventions, and maybe adopt some interventions that you actually know from your clinical experience don't work. And so I am one who's a little less concerned about it from that standpoint. I am concerned that our medical literature as a whole maybe gets more and more biased, right? We know there's publication bias, and I think investigators or their funders are getting more and more sophisticated about making these trials artificially positive in such a complicated way that, Mr. Practicing Doctor Me or Mr. Medical Student You, have trouble figuring it all out.
That's a point that I discussed with Vinay, that actually he's of the conclusion that these trials should really be designed by independent experts, because otherwise it's just an arms race and you can always do more to twist things. It's almost like whack-a-mole. You can deal with one thing and almost mandate against it.
Right. We absolutely we wrote about that in Ending Medical Reversal, and I think it's absolutely true. You think about it, and it's a little hard to imagine it happening. But boy, if you could say that that drug companies develop drugs, test drugs, but when you're getting to the clinical trial stage, what happens is that they put in the money and it's designed by sort of independent investigators. Wow, we'd have a lot better data out there.
And you talked a couple of minutes ago, which I thought was really interesting, about using clinical experience. And I was wondering, how you approach when to use your clinical experience and when not to, and where the balance here lies?
It's a great question. So, I mean, I think in a 30,000 foot view of practice, what my clinical experience has done is it has made me more conservative about adopting new drugs. Right? I've seen enough things failed. I've studied reversal enough to know that happens, and so I am seldom the first person to adopt a new drug. On individual people, I think maybe what happens is it's a little on the almost post-marketing side. That if I understand why a drug should work, and I've read the literature, and I'm like, yeah, I'm willing to jump in on this. But on the first 5 patients I use it, I'm not impressed. That will actually affect my prescribing habits. And that is certainly true for a number of drugs that I've used that I've said, this isn't the right thing for me.
And should that be the case? Because you could say the counter that actually it could be a statistically insignificant, almost like flipping 2 or 5 heads on a coin in a row.
Right, right. And you would be completely right to say, boy, Dr. Cifu, you are talking out of your, both sides of your mouth, because you're on the one hand saying we need to practice evidence-based medicine. On the other hand, that is such a perfect example of, pathetic anecdotal medicine that you're letting the outcomes of 5 of your own patients, based on their maybe subjective outcomes, ignore the literature. But as we said, the human body's complicated. The evidence isn't perfect. You need to bring everything together. And that's a little bit why, I don't think we're going to be replaced by artificial intelligence anytime soon, because there's a lot of nuance here.
And again, do you think that this sort of approach is justified by a literature that is often not answering exactly the questions that you'd like it to answer? Would you adopt a different approach if the literature was much more robust around the drug that you're giving to 5 patients in a row who show a bad response on nothing at all?
Sure. And recognizing that, right, I think what doesn't happen enough is that we get data on patients in a trial, a drug gets out there, but then we don't have sort of post-approval studies that say, okay, look, how does this work in the 90% of people that would have been excluded from that trial?
Certainly a discrepancy between the trial population and the population that's actually going to use it is an enormous issue. And I love this, the idea, I think it might have been in Ending Medical Reversal, actually, that a trial outcome is only a surrogate outcome for its real world usage, which is the real thing that we're interested in there.
Yeah. I hope that was in the book. That sounds great.
If
it wasn't, I'll steal it from you in the future.
No, it definitely wasn't me. But I might have written about it in Malignant, because I read them kind of back to back there. I'm conscious of time. We've been talking an hour, so I might close it off there. But thank you so much for chatting with me. It's been really great. We've touched upon all sorts of things. Yeah, no, really a pleasure talking to you. Great questions. And I enjoy. You made me think about some things, which I always appreciate. So thank you. Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.